Good morning. My name is James Danger. This is one of my third aid IVF data YouTube videos, and today I'd like to talk about preeclampsia and IVF and its relationship to oocyte donation. It's based on a paper published 3 years ago. Preeclampsia in pregnancies resulting from oocyte donation, natural conceptions, and IVF: a systematic review and meta-analysis. We all know that oocyte donation is important. In 1984, the first baby was conceived from oocyte donation, and from that day forward, it has allowed many young women suffering from primary ovarian insufficiency to achieve pregnancies. Over the years, the indication for oocyte donation has expanded, first to menopausal women with advanced age and to unexpected low ovarian reserve, and then also to failed treatment for unexplained infertility. But nowadays, it's getting into the general population, even for non-medical reasons such as shared lesbian motherhood or reception of oocytes from partner in what's called ROPA. However, if you're a client of IVF, you need to recognise there is a downside risk to this. The oocyte donation bears the risk of adverse pregnancy and poor perinatal outcomes, including first trimester bleeding, gestational age, diabetes, low birth weight, preterm birth, intrauterine growth restrictions, and hypertensive disorders such as gestational hypertension and preeclampsia. And I just need to go back and make a point that I'm not a medical person, and this is not medical advice. I'm just reporting on a series of publications in relation to preeclampsia. I think this is the first of several. So once again, I'm not a medical person, and this is not medical advice, and you should refer any information to your medical practitioner. Although the pathophysiology of preeclampsia is poorly understood both in natural as well as medical assisted pregnancies, it's suggested that the higher incidence of preeclampsia and oocyte donation may be due to the fact that the transferred embryos are completely allergenic to the recipient. And I'm not quite sure whether that's true in 2025, but that was the view in 2022. In the general population, preeclampsia develops in 2 to 8% of all pregnancies. It can be classified as mild, severe, early onset, and especially severe early onset. Preeclampsia bears a high risk of high maternal morbidity, perinatal death, and severe neonatal morbidity, resulting in a worldwide annual death rate of 70,000 mothers and 500,000 infants. I find that almost incomprehensible, and it makes you stop and think. But amongst all the risks for preeclampsia, once I'm not a medical person, is in the relative risks. There are a couple of things that may relate to infertile couples, including insulin-dependent diabetes, multiple pregnancies, nulliparity, obesity, and mature age. So what is the question of preeclampsia in pregnancies after oocyte donation compared to natural conceptions? This has been prompted by a series of articles, and I'll just go and list 6 here. In 1998, they suggested oocyte donation was linked to preeclampsia. And this one here in 1999, the rate of gestational hypertension in pregnancy for donated gametes was possibly a maternal genetic component. And that one here in 2005, American Journal of Obstetrics and Gynecology, nulliparous pregnancies received using double embryo transfers are associated with increased risk of pregnancy-induced hypertension. However, they say excellent outcomes can still be expected. And there's more of these in the same 2010. They're highlighting the fact that donor oocytes and cryopreserved Thora oocytes may be at higher risk. And this one, human reproduction 2012, demonstrating that women aged 43 or older have a higher risk of preeclampsia. And this one in 2012, looking at donor oocyte pregnancies, the oocyte donation is associated with an increased risk of pregnancy-induced hypertension and first trimester bleeding, independent of the recipient's age, parity, and independent of the age of the donor or the partner. However, I think, but this is also true even in 2025. The article published 2 days ago suggests that there is still a risk of postpartum hemorrhage associated with oocyte donation compared to IVF. So there's something funny going on about using oocyte donation. And just basically this is just showing the difference in postpartum hemorrhage, which is sort of the same line as preeclampsia. So what was already known, the indication of oocyte donation is expanding to lesbian women requiring shared lesbian motherhood. Previous reviews have shown that the risk of preeclampsia is higher in pregnancies after oocyte donation, but however, the classification on the severity of preeclampsia is lacking, and furthermore, that the actual prevalence is still unclear for oocyte donation. And just by way of a spoiler, this is what they're going to demonstrate, that after oocyte donation is 4 to 5 times higher risk of preeclampsia in natural conception and 2 to 3 times higher after IVF. But the point here is this risk that needs to be provided to all clients considering any form of oocyte donation, or, as we'll see later on, any transfer in an artificial cycle. And so the further implications of this is that 1 in 6 women will suffer preeclampsia after oocyte donation. It's 1 in 6. Although it's uncertain whether these risks are consistent for lesbian couples, that is, the non-infertile women or people who have normal ovulating cycles, where they feel that women who can conceive naturally would be advised to reconsider artificial conception cycles. In women with primary ovarian insufficiency, they feel the risk the factors may increase the risk of preeclampsia, such as double embryo transfer should be avoided wherever possible. So here's the data. They found in their search 430 articles might be of interest, and they've narrowed it down to 27. And this is what they find. This forest plot looks really confusing. If you don't know what it is, you'll probably stop and have a cup of coffee. But basically, these are all the different studies they looked at. These are the number of cases, 1,000 oocyte donation to 1 over a million natural conception cycles. And the square tells you where the mean difference is, the relative risk. That's lower risk, no risk, or high risk. And this is the summary, the triangle. And the bigger the triangle, the greater the risk. And you see here for all single pregnancies for older women, twin pregnancies, and where for younger and older women, where we don't know the period, they all tell the same story, that the risk of oocyte donation, of preeclampsia with oocyte donation, was between 11 and 15%. And if you want to look at severe preeclampsia, that's a really dangerous one. For oocyte donation, natural conception, the risk is still the same, 2 to 3 to 5%. It's highly significant. And if you want to then compare oocyte donation to other IVF, where this population here are infertile couples, 2,500 against 52,000, the effect is the same, not as strong as for natural conceptions, but all the summary markers all indicate that there is a risk. And overall, the risk of oocyte donation was between 13 and 18% compared to other IVF cycles. And for preeclampsia, much the same sort of thing, just not quite as well spread, 6 to 12%. But here's the summary of it. Basically, for preeclampsia, right across the board, excuse me, there's a 1 in 6 chance, 15% of preeclampsia after oocyte donation compared to 3% in the natural population, 3 and 5% for IVF. And of these 6%, a third of those will be really severe, and compared to 0.5%, hardly anything in the background population, and 1.5% for IVF. So that is a real risk. So they now want to make a case that oocyte donation should be not thrown, should be like throwing the baby out with the bathwater. They're making a special case for ovum donation. They're saying that about 4% of all couples remain involuntary childless, which can lead to depression, anxiety, and grief. And oocyte donation is at present the last resort option for women with ovarian insufficiency and for the vast majority of women of advanced reproductive age to fulfill their deeply felt wish for a child. And they talk on that this is now being spread in the general population with lesbian couples using this technology. And these are healthy people, so the risk of preeclampsia should be no more than the background rate. But here's the problem. FETs are increasing the predominant means of embryo transfer due to blastocyst culture and genetic testing, PGTA, but also increasing women having oocytes frozen and then thawed and transferred later on. It's also being used in the general population for same sex, but there's also going to be a bigger one here of polygenic testing, which will even be huge. But all those cases require embryos to be frozen and thawed and put back in an artificial FET cycle. But artificial cycles in busy clinics give you a better management tool over natural cycles just because they're so busy. And the other thing I need to make a point is that birth and neonatal outcomes are not part of an IVF clinic's radar. They're not usually handled by non-IVF obstetric staff, and the awareness of the risk of preeclampsia and other hematological births is not necessarily self-evident. There's a lot of noise. There's also a very slow acceptance of there is an increased risk and a very strong reluctance to move away from artificial cycle FETs. But even in 2023, the reasons for this were unclear. And I just make the point that there was a query to the paper where they said the absence of corpus luteum could therefore be account for a considerable part of the increased preeclampsia rate reported in oocyte recipients. Both an impaired cardiovascular system with increasing age and the challenges of the immune system in adapting to a completely allogenic fetus may mutually reinforce the susceptibility to a lack of vasoactive corpus luteum factors. A significant portion of oocyte recipients are still able to ovulate and produce a corpus luteum, and this is the corpus luteum is a rupture follicle. This is certainly the case for shared motherhood lesbian couples. In these women, the true risk increase of preeclampsia may be substantially lower than actually being reported. And the authors reply to make the valid point that the majority of oocyte donation recipients are likely to have had an embryo transfer in artificial cycle, assuming that the artificial cycles were mostly used as the majority of oocyte recipients suffer from premature ovarian failure. This may have confounded the results of performing ETs in artificial cycles, has been shown to increase preeclampsia compared to embryo transfers in natural cycles. In our review, we were indeed not able to adjust for this, nor were we able to adjust for frozen transfers or fresh transfers. No, just finish up and need to stop fairly soon. As we wrote in the concluding remarks of our review, the women should be informed about this increased risk of preeclampsia during a preconception consultation. We wholeheartedly agree that in all women who request oocyte donation, any factor that increases the risk of preeclampsia should be avoided. This includes avoiding, if possible, an embryo transfer in an artificial cycle or avoiding the transfer of multiple embryos. In the author's view, we maintain that oocyte donation should not be offered lightly to fertile, normal cycling women. And just to let you know where I'm going in my second video, the second video will actually review this particular issue of neonatal outcomes between natural cycles and artificial cycles, another systemic review. And basically, I can tell you that the implication of this study confirms that natural cycle FET decreases the risk of adverse obstetric and neonatal outcomes. They estimate that for each adverse outcome, the use of natural cycle FETs may prevent 4 to 22 cases per 1,000 women. Consequently, natural cycle FETs should be preferred treatment in women with ovulatory cycles undergoing FET, not just oocyte donation, but all frozen transfers. Based on the very low quality of evidence, the risk of preterm birth may be decreased if the TIL support is given, but that's another story. And I would just like to finish here and remind you that my name is James Stanger. I'm an embryologist with 50 years experience. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. If you like what I'm doing, press subscribe and leave a comment. So one quick plug for my own other program, ferdaid.com, which is an online EQA and training program in IVF embryology. These are the different schemes it offers. You can enroll as a trainee as a professional, small clinic or large multi-lab clinics, and can be used for training or competency accreditation. And that is your lot for the week. I'd like to thank you for your attention and wish you well on your journey. And at this point, I'd like to say au revoir.